Assalamu alaikum everyone and a very good morning to all of you. I'm Dr. Rabika Hamid, representing the Department of Pharmacy Services of Indus Hospital and Health Network, serving as an inpatient pharmacist for almost an year. Welcome you all at ICON 2022 and I will be moderating this session today. Keeping with par of academic and institutional excellence, the IHHN has successfully organized its prestigious annual conference, bringing together the brightest minds of healthcare system to share their pool of knowledge in order to further improvise the provision of quality healthcare. In accordance with this doctrine, we today start officially with this holy name of Allah, who imbued the humans with unquenchable thirst of knowledge.
पनाह मांगता हूँ मैं अल्लाह की शैतान मरदूद से। बिस्मिल्लाहिर्रहमानिर्रहीम। शुरू अल्लाह का नाम लेकर जो बड़ा मेहरबान निहायत रहम वाला है।
इन्ना अअतैनाकल कौसर फसल्लि लिरब्बिक वन्हर इन्न शानिअक हुवल अबतर।
ए नबी सल्लल्लाहु अलैहि वसल्लम, हमने तुमको कौसर यानी बहुत ज्यादा भलाई अता फरमाई है, तो अपने परवरदिगार के लिए नमाज पढ़ा करो और कुर्बानी किया करो। कुछ शक नहीं कि तुम्हारा दुश्मन ही बेनाम रहेगा।
Subhanallah. It is our pharmacy service legacy. Before any session, we play national anthem. So I will request you all to please pay attention to national anthem. Continuing on, now I'd like to call Dr. Aslam Shah. He is the Senior Manager of Pharmacy Services and Supply Chain of IHHN, serving for more than 25 years. His dynamic leadership and prolific motivational demeanor has helped construct and elevate the Department of Pharmacy Services from a single room med surg to present day's multifaceted department, encompassing clinical pharmacy, extemporaneous and cytotoxic pharmaceutical. I'm so sorry. Actually, Dr. Aslam is not online yet. I'll further continue the session. Childhood cancers have been prevalent in the young generation and constitute a huge cost on R&D and healthcare system all around the world. Being in infancy in many parts of the world, especially in developing countries, oncology pharmacy is a much neglected discipline relative to its contemporary fields. However, many inspiring figures from around the world are working selflessly to ensure that the young innocent kids get the best of treatment. As such, our next session is on oncology pharmacy from good to great. For this, I'd like to invite Dr. Sherif Kamal. Dr. Sherif Kamal is an Egyptian clinical pharmacist with more than 15 years of experience in this field, involved in the planning, designing, and implementation of pharmaceutical care in oncology centers as senior clinical pharmacy consultant. Sharif Kamal is the Director of Pharmaceutical Services at the Children's Cancer Hospital in Egypt for more than 13 years. He is the recipient the Egyptian Hospital Pharmacists Association Award and founder of the Egyptian Association of Clinical Pharmacists in 2010. He is also a certified Lean Six Sigma belt. Please welcome Dr. Sherif Kamal.
Team conference. My name is Sherif Kamal, and today I am going to take you into a journey of the oncology pharmacy from good to great, and how translating theory into practice was the model for the Department of Pharmaceutical Services and Sciences in the Children's Cancer Hospital in Egypt. Here you can see the progress from 2007 when we started in the new Children's Cancer Hospital until today, where we served first for the basic functions like IV admixture, inpatient dispensing pharmacy, picky lab, and then moved to pharmacogenomics, nutritional services, radiology, OR, and we're going to see the advanced services and specialties we do across the hospital. Here also, we developed for our staff a very unique clinical pharmacy pathway, so that the clinical pharmacist from entering our hospital and as a specialist until 10 years, where there will be a consultant in clinical pharmacy specialty, they know exactly what they do. And also, we provided them with protected time for academic track according to their position. And here you can see the main 5 dimensions that we are working and serving: quality patient care, smart education, research, capacity building, outreach, and center of excellence. So the quality patient care includes from supply chain until the direct patient care. In supply chain management, we incorporated clinical pharmacy to allow hospital pharmacy maintenance and development, and we used key performance indicators to allow us to evaluate our performance. In the IV admixture, we do nearly 3,000 preparation per day. We incorporated automation and total parental nutrition in our practice. We are now adding software integration that will allow us to make gravimetrical checking of our products. Here you can see how our IV admixture is separated into IV preparation area, receiving and verifying the orders, then IV admixtures, then IV checking and packaging. And here you can see our value chain map, where you can see our workflow by minutes for every station. In the dispensing pharmacy, we dispense an average of 60,000 medication doses with an average of 250,000 items charged every month. And here is our value process map, where you can see also we identified the required quality attributes for each step and the quality time for each step, from order entry to order review to printing the label to patient counseling, etc. Patient counseling for us started in a private room with using patient-centered educational material. Then we now have more than 5 rooms that you see here, glass rooms, that every patient will sit rather than sit behind a window. We use technology implementation for safe implementation of clinical pharmacy, starting from using order entry, order verification, workflow, and barcoding. In addition, also inpatient dispensing devices and multi-dose repackager, including automated dispensing for the outpatient. In the inpatient services, we cover all areas of patient service, pediatric oncology floors, ICU clinical pharmacy, OR, etc. For every 10 patients, we have a pharmacist that round with the physician, agree on the plan of care and then send it to the main station for implementation. Here you can see the process map we have done for our patient care areas, ward pharmacy, and central pharmacy. Here you can see how we were making this process to decrease the discharge medication preparation time. And here you will follow up with us the big five from the European Society of Oncology Pharmacy and the quality standard for oncology pharmacy practice we are implementing. We are making, as pharmacists, a great role in protocol management. And in this area, pharmacists prepare pre-printed orders protocols for all diseases we are using. Here you have low-grade glioma and acute lymphoblastic leukemia protocols. We attend all tumor boards, all committees, and pharmacists are encouraged to improve their knowledge and use pharmacoeconomics data in formulary selection and formulary decisions. Here you can have the inpatient services pharmacy key performance indicators, where we measure the overall percentage of pharmacist patient education forms, a reduction of medication waste, and turnaround time for emergency medication. In the ambulatory care service, we have a great team that is serving the outpatient clinic, the daycare treatment area, and take-home medication for the daycare treatment area. Here also you can see our pharmacists working in the multi-specialty clinics, from receiving the order to preparation to patient counseling. And here are the outpatient care service indicators. We transformed our PK lab to personalized medication management unit, having therapeutic drug monitoring, ultra performance liquid chromatography, LC mass, and pharmacogenomic screening. Here you can see how we measured the pharmacoeconomic impact of one gene and one medication that is going to reduce 300 days of hospitalization due to side effect of 6-mercaptopurine. We have pharmacists inside the OR with the surgeons, and they save 8 million pounds per year. Here are pre-printed orders they produce. And we have also in the emergency room, we have our pharmacist that is serving the patient. We have clinical nutrition services, pain management and palliative care services, nuclear pharmacy, hot lab, radio pharmacy that is serving contrast media and radiology, and patient counseling service, a drug information center that is producing our journal, drug journal. We have actual experienced clinical pharmacists. We practice evidence-based medicine. We have this insight of producing, not only answering questions, but being proactive and making guidelines. We believe that pharmacists are lifelong learners, and we have the models of translate theory into practice. Here you can find how we train our pharmacy students. Also, here is our staff for learning and development and courses we do. Also, we made a preceptorship program with School of Pharmacy in Colorado University, SCAGS, and University of Maryland School of Pharmacy to serve our PharmD program and residency program. Here is an example of a dispensing module training that we do at our facility. We have in the pharmacy a decision support team that is helping us in pharmacy informatics and in automation. They are making internal audits to provide us with gap analysis and improvement projects and patient safety projects. And here you can see the fishbone analysis we have done to prevent medication error in one of our programs. Here you can see how medication error documented on our clinical intervention as clinical pharmacy main role in the chemotherapy medication errors, in the supportive medication errors, in the antimicrobial medication errors, in the nutritional and contrast media and nuclear pharmacy intervention. We have a pharmacy-led antimicrobial stewardship program involving many phases like administrative and operational surveying and analysis, action plan, retrospective audit, prospective audit and feedback, actions and intervention. And we have now antimicrobial stewardship program pharmacist and infectious disease pharmacist. And here you can see how we automated our clinical justification for restricted forms and our clinical interventions as pharmacists. We track and report antibiotic use and outcomes by process and outcome measures, including DDD, DOT, length of stay, and compliance of antimicrobial stewardship program recommendation and antimicrobial appropriateness. Here you can see restricted medication reports as we follow every day. We calculate resistance in our antibiogram. And in my PhD, I came out with the aware index for the WHO, and I produced for the hospital a traffic light model. So you see in the red are reserve medication like vancomycin, linezolid, colistin, and buzoconazole. And here you can see how we produce our results as a traffic light model. Here you can see how we use our work in progress to improve our safety by making barcoding for product validation. And we already upgraded our Pixis, and we produced a committee for performance improvement and pharmacy practice research. We have many academic achievements. We have 35 posters, 5 papers. We have many of our pharmacists are either oncology board certified, nutrition board certified. Also others have black belt, master black belt, and other GCI accredited programs. We make outreach programs with our dear friends all around the world, in the Arab area and in Africa. We also have done pharmacy renovation to meet our measure to excellence, which is satisfaction of our patients. And here you can see our clinical pharmacy entrance. And thank you very much for keeping in touch.
Thank you so much, Dr. Sherif Kamal, for your informative session. If you have any queries, kindly ask at the end of each particular session, or you can drop your question in your chat box. Thank you. Moving forward to our next speaker, Dr. Mujahid Hussain. Dr. Mujahid has completed PharmD in 2008 from University of St. Jamshoro. Did post-graduation in clinical pharmacy from University Sains, Malaysia. Dr. Hussain has 14 years experience in hospital pharmacy services at different positions with JCIA accredited hospitals in Pakistan as well as abroad. He practiced as hospital pharmacist in AKUH, awarded as Best Staff Pharmacist with Best Pharmacy Satellite Award in addition. In abroad, served as inpatient pharmacist in Dr. Suleiman Al Habib Medical Group, with additional practices in clinical pharmacy services, specially focused on antimicrobial stewardship. Dr. Hussain currently practices as clinical pharmacist infectious disease at IHHN since 2019. Additionally, served as secretary for clinical pharmacy committee involved in research projects, different CME activities at IHHN.
For this icon event for 2022. Today's topic to discuss is to treat infections become serious challenge nowadays. We will a little bit talk about some various aspects of infections, but especially the bacterial infections come around the globe and what the consequences nowadays. That's my disclosure. I have no relationship with any commercial interest for any study purposes. The material used in this presentation is based on the standard guidelines and references. If we begin with the introduction, as we know, this person is a Sir Alexander Fleming, is the one who is going to invent the penicillins. Let's begin. What are the antimicrobials by definition? These are the natural or synthetic substance that kills or inhibits growth of microbes, hence can be used as to prevent and treat infections. What type of antimicrobials currently in use, like antibacterials, which have effect against the bacteria as an inhibitions or cidal action, like bacterial pneumonia. What antiviral? These are against antivirus, like we have example HIV infections, influenza virus, and Hep B viral. Antifungals, also known as antimycotic agents, which have action against the fungal infections like Candida and PCP infections. Antiparasitics, these agents against the parasites. If we'll go through the classification, there are different modes of classification of antimicrobials. Most likely for the antibiotics is based on the mechanism, mode of action of these drugs, like bacteriostatic in nature, like a bactericidal in nature. They have the action on the cell wall of the bacteria, cell membrane, protein synthesis, and DNA garase and folic acid synthesis inhibitions. If we'll go through the nature of the drug, nature of the antimicrobial, some drugs are hydrophilic in nature, some antimicrobials are lipophilic in nature. There's another classification mode that's based on spectrum of activity of antibiotics. Some antibiotics are narrow spectrum, some extended spectrum. Some have the broad spectrum coverage that can cover anaerobes, gram-negative and gram-positive bacteria. Another new classification could be based on the PK/PD relationship. This is pharmacokinetic and pharmacodynamic relationship. Later on, we'll discuss in detail. Most likely is the time dependent and the concentration dependent. Time dependent, just like time or MIC, like we have the beta lactams, and concentration dependent might be Cmax or MIC, like aminoglycosides we have. Another classification on the chemical moiety, chemical structure, that could be a beta lactams, lincosamide, aminoglycoside, quinolones, macrolides, sulfonamides, rifamycins, and miscellaneous. Glycopeptides are also there. Okay, a little bit talk about the antimicrobial discovery and resistance development. As we discussed, like penicillins have been invented by Sir Alexander Fleming in 1941. But later on, the next year, it's going to be a resistance against the Staphylococcus. Then there's an invention for the polymyxin in 6 decades before. Then also there's a development in 1960, MRSA methicillin resistance. And later on, it became a serious challenge for the healthcare professionals. This is a pipeline from 1940 till 2020. If you see, there are many, once the antibiotic is developed, in the same year or a year later, there's a development of resistance against that one. We have example like ESBL in 1980s, and we have example for the VRE, vancomycin resistance enterococci, in 1990. And currently is some challenge for the healthcare professional. In 2010, we have the pan drug resistance Enterobacteriaceae family after development of this tigecycline and some other daptomycin against anti-MRSA agents. And also, with respect to antibacterial, we have some resistance pattern seen in this graph. If you see for the Candida, the development of resistance for the amphotericin in just 5 years before. Okay, as we know, this is microbes in body which are causing some infections, event, like if there's a skin-related infections, might be the floor of a skin, Staphylococcus aureus become infectious agent, like for the intestine, it's E. coli. Like respiratory tract infections, we can go think for the streptococci in the or Haemophilus influenza and so on. Okay, once we start with the use of antibiotics in the human being, there's the development of antimicrobial resistance. Like what's that? Antimicrobial for treating infections lose their efficacy because of microbes changed by one mechanism, mutation of the microbe, or acquired genetic information from other microbe. So that's developed the resistance. There's the antibacterial resistance, antiviral and antiparasitic, as well as antifungal resistance, as we've seen. How it's spread, generally, we talk about is start from antimicrobial use, like in animal sectors, antibiotics are given to the animals, and crops sector, they are using. And from other hand, if you see antibiotics are given to the patient and develop the resistance in the bacteria, in the gut, sorry. Then patient go for the hospitalization, and the animals who taken for their growth antibiotic use, the animal develop drug resistance bacteria in the gut. Finally, what happened, this chain cycle ultimately hit the general public population. Drug resistance bacteria is spread by any means, from the food source, or from the animal source, or from the environmental source as well. So now we are facing the challenges like MDR, multi-drug resistance, XDR, extended drug resistance, and pan drug resistance. It means not sensitive to any antibiotic in the microbe class. What could be the possible further driven force for antimicrobial resistance, their use and misuse? Like fear of missing life-threatening infections. Once the clinician is going to prescribe antibiotic, he or she has a fear for the missing life-threatening infections. Heavy antimicrobial use result in that, and numerous complications for that respective patient. What could be the reasons? Like little functional reserve, pharmaceutical marketing pressure, that they have some targets to reach the prescriber, and it also increase the heavy use of antimicrobial. What are the reasons? There are some guidelines that you have to start initiate of antimicrobials in some scenarios. Diagnostic uncertainty in some conditions, or in some institutions might be there's a lack of adequate services for the diagnosis. Lack of knowledge, especially with respect to antibiotics and their use, where should be a particular coverage to be covered. ID specialist unavailability, that could be also a big reason. Severely ill patients that could raise a numerous infection complications. So we need a multiple antibiotic to be used in that, and breaches of natural barriers. And moreover, recently that we have seen a sudden outbreak leading to pandemic situation of COVID-19. And in this COVID-19, we don't know how we have to treat and how we have to go. Like throughout the globe, they use the azithromycin, that it have some cover against the viral infection. And also the length of a stay of patient in COVID-19, if it increase, there's a chances for the nosocomial infection. And again, we use some antimicrobial as a broad cover. So this could be a reason for the misuse of antibiotic or use, but the secondary outcomes will be the development of resistance in those patients. I want to share some antimicrobial resistance burden with the mortality. There's a data taken from the CDC website. They classified, CDC and WHO, they have classified the urgent threat and serious threat, some kind of bacteria. If you'll see, the mortality is a 2.8 million antibiotic resistance infection occur in the US in each year, and more than 35,000 people die as a result of that. What could be the bugs in urgent threat, like carbapenem resistance Acinetobacter? There's some data in 2017 about 700 deaths, and from the cases 8,500. Then Clostridium difficile in Western countries, there's a death rate is 12,800. Likewise, carbapenem resistance enterobacteriaceae is a CRE. It's well known as a nightmare bacteria. For this one, they have 1,100 death due to these cases of more than 3,000. What could be the serious threat like MDR, Pseudomonas? This bug's title is difficult to treat by the IDSA guidelines. So also in 2017, they have captured more than 2,500 deaths, and from the cases of 32,000, which with the diagnosed from the MDR Pseudomonas. And the other infections from gram-positive like VRE, vancomycin resistance enterococci, and MRSA. They have also significant data in Levant year in 2017. So from this slide, if we see the importance of these MDR bugs, that we have a serious challenge that how we can face. And this is the mortality data, and day by day is increasing. Little bit talk about molecular methods, what kind of resistance happening in behind once you use antibacterial agent or antimicrobial to target any bacteria inside, which is an infectious agent. Like we have a classical examples like Ambler class A, B, C, D. So there are some molecular mechanisms that they are going to produce resistance from the active site of serine base of amino acids like penicillinase and carbapenemase. Then there's a Ambler class B, zinc mediated is metallo-beta-lactamase, and Ambler class C, again from the serine base, cephalosporinase. It means the beta-lactamase produced in this class like cephalosporinase or penicillinases. It means the penicillins and cephalosporin won't work on such kind of resistance. And there's Ambler class D, which is a resemblance to A and C. It's an oxylinase. It's a very recent one. It's developed by the Pseudomonas and Acinetobacter. If we'll see the non-Ambler class, non-beta-lactamase mechanisms of resistance, there should be a efflux pump target site alteration, like we have an example of fluoroquinolone mutations, and target site protection, bypass of inhibitions, like we have example of Ceptran. What could be the impact of antimicrobial resistance? Increase morbidity and mortality. It means a failure to respond to first line and second line therapy, limited choice in selection for treating such kind of infection, because for example, the older antimicrobial agents has tried and tested, but they won't work on that one. And there should be a newer agents have a restricted licensing policies due to limited availability of data against them with respect to their efficacy and safety. Longer hospital stay, it's the impact on antimicrobial resistance. The patient length of stay in the hospital is increased because the antibiotic that can be offered in those patients are not working properly. And finally, with respect to use of antimicrobials, collateral damage. There's an increased use of broad spectrum lead to incidence of C. difficile infections or some organ failure like renal impairment or hepatic impairment due to some nephrotoxic or hepatotoxic antimicrobials. Generally, in the healthcare system, in a tertiary or secondary care, primary core team consists of clinicians, clinical pharmacists, nursing professionals, clinical microbiologists, and IC officers, infection control officers. They should, the story start with the infection like patient and the infectious agent. First, the relation start with their infection and the host defense mechanism of that respective patient. The immunity first try to resolve the infection if it's viral or some bacterial. If not, then patient become more sick, and the clinician is going to offer antimicrobial. Once the antimicrobial taken by the patient or administered to the patient, then we have to think the pharmacokinetic and toxicity of that drug. How that's safer for that particular respective patient. Then the third final one is the resistance. We have to think for the resistance and the pharmacodynamic effects of these antimicrobial which is offered to that patient. And there's some patients with the comorbid conditions like autoimmune disease or some diabetic complications. So these need some longer treatment options. Okay, that was a story for the globe, and just I want to talk for Indus Health and Hospital Network, Karachi, that how we are going to, as a pharmacy professional, what we done now currently. It was since from the 5 years or 7 years before, it was doing as a clinical services, clinical pharmacy services, but now it's strengthened more that we have now the infectious disease department, clinical pharmacists. We have a separate clinical pharmacist in medicines, which is looking for the nephro and pulmo and some internal medicines. We have separate surgery and orthopedic clinical pharmacists. Likewise, in critical care adult units, general peds, general critical peds, and peds oncology. So how clinical pharmacy work in Indus Hospital? There's a process that I want to show is hospital is 350 bedded hospital. Daily activity for the respective clinical pharmacists is that daily patient profile review, participate in the rounds with the physicians, with their respective team, put the progress notes as a pharmacotherapy care plan. For this one, the achievement for development of clinical pharmacy in the Indus Hospital, we have routinely around 300 per month intervention and more than 99% acceptance. That clinical pharmacist, if he or she found any change in pharmacotherapy plan, so they are communicating with the physician, and the medication plan should are changing according to their recommendations. That interventions are relevant to accurate dosing, adjusted dosing, followed by the culture sensitivity based modification in the therapy. Recently, it's a benchmark from our clinical services department that one of clinical pharmacists from the oncology department, she has been given the award for the patient safety champion in the bigger forum organized by the Sindh government and WHO. Okay, the solutions, what could be the solutions for that we discuss the antimicrobial resistance? There are some new antimicrobial agents suggested for the multi-drug resistance bacteria. Like if we can detect the KPC enzyme for the Enterobacteriaceae, the preferred agent is meropenem with combination of Weber-bactam, ceftazidime with combination of avibactam, or the alternative imipenem with combination with the relibactam. Likewise, that if it the resistance bug is MBL, then we can go with the ceftaz avibactam with the azotronium. If it is beta-lactam resistance pseudomonas, then we have the new guideline says you can go with the ceftolozane and tazobactam in that. If it is Acinetobacter resistance to beta-lactam, then we have the aminoglycoside irawacycline to be used as a preferred agent. And in last, if there is a beta-lactam and septron resistance Staphylomaltophilia, then we can go for the ceftazidime avibactam along with the azithromycin. But unfortunately, this data is worldwide. In practice, such kind of agents are available in developed countries. Unfortunately, in Pakistan, no agent, no antimicrobial agent listed here is available in Pakistan. So it's quite a serious challenge for us how we can treat such kind of infections. And the other reason is that if such kind of agents are available with us on a globally, these are highly contain a highly cost per day. It's start from $300 to $1,300 per day of a treatment cost. There are some alternative recommendations for treating some multi-drug resistance bacterial infections that depend on the MIC base. Like clinical pharmacists must have a role in that to know about the phenotypic and genotypic susceptibility profiles to anticipate in the resistance mechanism. That a clinical pharmacist specialized in infectious disease or as a journal can optimize the dosing strategy of antimicrobials. Like we have streptococci pneumonia. If it is MIC is 4 or less than that, there are recommendations that you can go with the intermediate MIC, that's 4, with the penicillins, 18 to 24 million units daily in divided doses. If there's enterococci faecium, we can go for the daptomycin. If the MIC is less than 4, we can give the 8 to 12 milligram per kg daily, because this drug has the susceptible dose dependent effect. Likewise, that Acinetobacter, we have some, we can use ampicillin if MIC is known with that. We can use colistin if it's MIC less than 2 with loading of 300 milligram. That could be equivalent to 9 million units, and with the maintenance of 4.5 to 5.5 million units Q12 hour. And also likewise that we have other agents, if known MIC with the tigecycline less than 2, so we can go for the loading dose 200 milligram, then 100 milligram Q12 as a maintenance. And also for the Pseudomonas, which was already we discussed is a difficult to treat bug. So we can go some agents like if we have a known ciprofloxacin MIC, if it is less than 0.5, then we can go for 400 milligram Q8 hours. And also for this one Pseudomonas, if we have known MIC for the piperacillin tazobactam, which is less than 16, then we can go for 4.5 gram Q6 hours, or the extended spectrum 4.5 gram over 8 hours. There are some, for the knowledge purpose, there are some investigational agents in a phase 3 trial, like 5th generation cephalosporin ceftobiprole, which has been studies for the MDR streptococci pneumonia, infection studies for the CAPE and this acute bacterial skin and skin structure infections. Like there are some other listed here, like cefepime, 4th generation cephalosporin with combination of boronate inhibitors. If you see, these are the limited agents, and they have the particular indications that they are in development process in phase 3 trials. So again, it's a challenge because we don't have much antibiotics to treat the resistance bug. What other things we can consider to control the resistance, like pharmacokinetic and pharmacodynamic considerations? As we discussed earlier, some of these are the time dependent and some of these are the concentration dependent. Like we have example in that concentration dependent is aminoglycosides, and for the time dependent, most of the beta lactams are the time dependent antibiotics. What concept is that time dependence? It means throughout the time the drug remain in the serum, their MIC, their time over MIC for a longer time. If it's a prolonged infusion for the beta lactams, they have the good effect, better effect as compared to the short effect. What more consideration to be done once you are prescribing antimicrobial in terms of PKPD considerations? Like we have to go for the lipid solubility, nature of the drug, as we discussed, absorption, what's the bioavailability of the drug, is there any interactions or GI conditions, that acidic medium or basic mediums. We can go for the metabolism, is a linear or non-linear. We can go for the excretion of that antimicrobial, from which route is going to be excreted. If it is not from the renal, it couldn't be a good for the some UTI infections in that. There are some other factors, patient factors, like volume of distributions can alter in some situations, like burn patients, like in patients in the ICU because of fluid resuscitations. there's some change in the kinetics, protein binding for the site of infection, creatinine clearance of the patient, and also antimicrobial factors like we discussed earlier, hydrophilic, lipophilic, and nature of antibiotic is acidal in nature or bacteriostatic in nature. What also other factors we have to see? Obesity, there are some examples like reduced tissue penetration, shorter mean half-life, increased volume of distribution, and increased clearance. We have the examples in that. If the patient is obese, then we have to think with the frequent dosing or with the higher dosing in that those patients. What other solution is the best one nowadays in practice is the development of antimicrobial stewardship in the institutions as well as the community level and as a country level, that we should encourage the antimicrobial stewardship program to control the resistance in that. And what could be the core elements for the antimicrobial stewardship program? First of all, the hospital, if we are discussing for the hospital leadership commitment, that include accountability, then there should be a person who is accountable, fully charged, usually the ID physician and the ID pharmacist, and the pharmacy expertise specialized like clinical pharmacists or ID pharmacists. Action, what could be the action for this stewardship program as a core element is the prospective audit and feedback of such antibiotic use, tracking and monitoring that what kind of resistance pattern is in your institution, and what prescribing behavior is occurring in your institution. There are some different departments in the hospital, they are going to prescribe their antibiotic. So antimicrobial stewardship program is giving help to respective primary teams to in selection of antimicrobial best use for that patient. Then also for the core element of antimicrobial stewardship is education, that what's the best use with safely of respective antibiotic and what could be the best to cover such kind of infection. And finally, after all these activities, we have go for the reporting, that how what's the pattern of utilization of antimicrobials in the institutions, and how we can overcome such issue. What could be the action plan? The most effective action plan of antimicrobial stewardship program globally is prospective audit and feedback and pre-authorization are the most effective for the intervention in the hospital setup. What we can do in that, this is a collaborative approach. So on a pharmacy-based interventions is a documentation of antimicrobial indications, automatic changes from IV to PO, because per oral route of antibiotic is a safer as compared to that. And for the dose adjustments and dose optimizations, like we discussed, beta-lactams should be given extended infusions for the MBR, and duplicate alerts in the system, that not necessary that any two antibiotic covering the same bug. So if it is not needed, to discontinue that. What other from the microbiology based intervention in the stewardship program? The selective reporting of antimicrobial MICs results, comments in the microbiology reports that might be a colonizer or contaminant, anti-biogram development separately for the critical care units and the wards, implementation of the rapid diagnostic methods in that. What could be the nursing-based interventions for the antimicrobials? Optimizing the microbiological cultures to reduce contaminations, intravenous to oral transitions, promoting antimicrobial reviews for the timeouts. And also as a whole, as a team for the clinicians, there should be common infections based interventions like community acquired pneumonia. There should be a diagnostic stewardship, de-escalation to CS based optimized duration, because upper respiratory tract infections and lower, somehow they have a differential the same as with the viral infections like UTIs, unnecessary urine cultures, are treating asymptomatic bacteria which doesn't need any antibiotic for the asymptomatic bacteria infections, like patient have no any lower urinary system uh, symptoms. So sometimes it's appearing E. coli in the urine cultures, but patient is asymptomatic. So that patient doesn't need any antibiotic in that. Likewise, skin and soft tissue infections, unnecessary cover of for the MRSA. If you really think that this patient need for the MRSA, then we can go for the vancomycin. If you didn't think it's the MSSA, so no need for to give vancomycin. So we can go for the first generation cephalosporin or so on to save the vancomycin for the MRSA bugs, and also to reduce the vancomycin resistance against that. There are some rapid diagnostic testing for the gram-positive and gram-negative organisms, which are on the molecular basis. They can detect what kind of resistance is happening in particular patient, particular with respect to particular infections. So early rapid diagnosis is helpful for the de-escalation of the antibiotics and leading to decreased exposure of these antibiotics to the patient and leading to decreased antimicrobial resistance. There are some multi-TOF methods, PCRs are there, and some MPCRs are there. PNA fish models are there for different bugs that they are giving results in half an hour, 1 hour, and maximum in 3 to 5 hours. Antimicrobial, as we discussed, best solution to control antimicrobial resistance, like systemic approach. Practically, what we have to see on a pharmacy point of view or as a healthcare point of view, there should be a right prescribing patient, right drug with respect to dose, with respect to route and duration of these one. Usually in a healthcare system, the antibiotic prescribed like surgical prophylaxis, medical prophylaxis, empiric therapy. Once you doesn't know the infection, what kind of bacteria possible there, so you start as empiric therapy. But it should be reviewed within 48 to 72 hours for the narrowing down the spectrum in that. And the target therapy, once you know the cultures, you target that particular bug in that. And sometimes there's a synergy therapy that in critical patients we need to start with the two antimicrobials in that. And also there's some classic example to start. Once you start the antimicrobial, just remember this acronym, MIND-ME. MIND-ME means microbiology guide therapy indication should be evidence-based, narrowest spectrum wherever possible, dosage appropriate with the site and type of infection, because some antibiotics like they couldn't have a penetration, they couldn't have a serum concentration in the blood. So we have to select the right dosage and right drug for that one, and minimize the duration of therapy, because there are some studies that in some classical infections like CAP, Vagera, and the UTIs, there should be a short duration is better as compared to longer duration. Ensure the monotherapy in the most cases wherever applicable. Okay, there are the previous a few conversation among the healthcare providers that I am going to share. Might be it's helpful with you, whosoever is going to implement the stewardship program or controlling the antimicrobial use. Like in our system, if ID pharmacist is going to ask what's the reason to start with the vancomycin, the replies from the residents is gram-positive cover. So it couldn't be appropriate. If do you really think that it's a MRSA, then you want to cover other than the MRSA. So the use of vancomycin can be decreased for that to remind the primary resident for the prescription. Then also sometimes any reason to continue surgical prophylaxis. Usually surgical prophylaxis in elective cases, recommendations are there only single dose or maximum for 3 doses post-op. So sometimes they are giving beyond the 24 hours. So we should have a particular reason to continue with these surgical prophylaxis antimicrobials. And also, once you want to continue, is a standard that we should document in the patient profile what's the reason for continuation of antimicrobial and what should be the indication. As if your institution have the ID or stewardship department operational, then they could review and they could give you help in that, in selection of antimicrobial and in for the better treatment of the patient. The reason from changing peptides to meropenem, since as we know, these both antimicrobials have almost the same coverage. So what could be the reason from changing peptides to meropenem? No response on peptides, it means something is resistance happening in such kind of patients who's on peptides. Have we checked some PKPD considerations? And also in some institutions is a 50% less cost as compared to meropenem. Reason for start a broad spectrum antimicrobial, since there's no any urinary symptoms and the patient is febrile. Patient have a burning, the answer is coming like patient have a burning micturition in the past. So this could not be the reason to start with UTI for cystitis in such cases. And there are some other reasons, like we have an overlapping of a spectrum. Sometimes you will find the clinician is going to prescribe meropenem with the metronidazole. If they are thinking for the anaerobics cover, then the peptides or meropenem can cover anaerobics. So no need to add the metronidazole in such kind of scenario. If they are giving for the diarrhea, then they should think for it is a antimicrobial associated diarrhea, some C. difficile or non-infectious diarrhea. Any reason for start of dual or triple antibiotics? Sometimes ID pharmacist is going to ask from the primary team. The reply is the patient in sepsis. Then they should, as a standard, should write the SOFA scores in the documentation, that how their SOFA score is show us the patient in sepsis or no. Viral versus bacterial respiratory tract infection. Any reason to add colistin to vancomycin and meropenem? Since no response, patient is going in shock. What type of shock is that? Is ID consulted, because you start with the last line agents of antimicrobials. And also they can increase the collateral damage for this. Okay, we develop in Indus Hospital the format on the basis that we do the stewardship program. There are some reasons from the clinical pharmacist infectious disease that he is going to review that. These are the reasons that on these reasons, the clinical pharmacist can put up a case in the stewardship program, like microbe is resistance to current antimicrobial, antibiotic is not needed, or culture negative, restricted antibiotic started, microbe is susceptible to narrow spectrum or first line agent for the target therapy, overlapping of spectrum, incorrect dosing prescribed, subtherapeutic or supratherapeutic dosing. You can go for, he can put a reason for the AS, surgical prophylaxis more than 24 hours, non-compliance of institution guidelines, and empiric therapy more than 72 hours. Like we discussed for the sepsis patient, it needs some review on 48 to 72 hours. No clinical response to current therapy. You have given the dual antibiotics, but still patient have a rise in TLCs and patient have a fever, and the condition is, clinical condition is worsening there. The duration of therapy, classical low-hanging fruit is rigidity, like more than 7 days is still on antibiotic. What could be the reason there? Contraindications or adverse effects due to antibiotic use, and inappropriate penetration to the infection site. As we discussed, some antibiotic cannot be good for the meningitis, or some cannot be good for the acidic medium, or some cannot be good for the bloodstream infections. Not achieving serum concentration. There are some antibiotics which need some therapeutic drug monitoring. If they are not achieving on optimal dosing, then we have to decide with the safety and efficacy of these antibiotics. and also a low cost option available. If it is pen sensitive, then the ID pharmacist is thinking for low cost option available for respective patient of treatment, and also from IV to PO. Then what could be the possible solutions? These were the reasons: the change in dosage IV to PO, switching from PO to IV, change in frequency, change in duration of therapy, dose adjustments, hepatic or renal, de-escalation of therapy, escalation or change in therapy, addition of antimicrobials to current regimen, obtain the culture and continue current therapy. Sometimes the primary teams are prescribing, but they forget to send the cultures. So there's a recommendation for that. Check or send the levels for some antimicrobials, like we have vancomycin as an example, aminoglycoside, voriconazole, in some cases for the cholesterol as well. Check for the MIC, modify therapy according to individualized PKPD parameters. Like the dosing strategy that we are using in the hospital is based on the some evidence-based guidelines are in the drug references, but the patient who is admitted in your institution have some different physiology, different physiological parameters. So clinical pharmacist is looking for to analyze the dosing strategy for the PKPD parameters on that. Stop of therapy, continue current therapy, and some other options. For the stewardship program, further what we done the development, the aware classification. It's a reference taken from the WHO model. Like we categorize in 3 categories of antibiotics. Category A is the reserve group, which includes like cholesterol, tigecycline, linezolid, and amphotericin, voriconazole, with the system alert with the indication that you are prescribing this one category A, which is a reserve group, and the auto ID consult has been processed. Category B, which promptly assess that the most resistance developed due to this category, like this include carbapenems, piperacillin, tazobactam, fluoroquinolones, vancomycin, as macrolides are there, antifungals, fosfomycin, etc. Category C is the excess group. Mostly it contains the penicillins, first and second generation cephalosporins that can be used for the surgical prophylaxis, aminoglycosides, and so on. Okay, practice at the Indus Hospital. I want to share a little data that since last 1 year, proactively we are doing stewardship. But before 1 year, we were doing also a stewardship. But in this scenario, we more involved in stewardship to control the antimicrobial resistance and the best of the treatment therapy to the respective patient. We have the low-hanging fruit ASP plan. What is the process? Step 1, the ID pharmacist generate the report of these categories on daily basis, review patient profiles, make case summaries. Step 2, the case presentation and discuss with the ID consultant on rotation with the stewardship. System review by the ID consultant, review to see the patient on a bedside. Step 3, the ASP team, antimicrobial stewardship team, contact primary team for the case discussion and clear plan, and state their recommendations to put in the progress note to review again in 24 hours for the adherence. And step 4 is some data compilation and their reports. The current strategy based on prospective audit and feedback. This is the data, which was a low-hanging fruit strategy of 6 months data. We put up cases, 121 cases in antimicrobial stewardship program, and we found the adherence rate of 72%. But still, there's a 28% to be practiced to increase this adherences or find some reasons. And for the secondary outcomes, we saved the doses like around 600 doses saved and cost saved 0.6 million for this 120 patients. The current practice, like last 2 month data, is 134 cases in antimicrobial stewardship program put by the ID pharmacists. Uh, and the outcome of that, the adherence or advice followed by the primary teams of the ASP team recommendations is increased from 72 to 78%. And these are the graph shows that what kind of antibiotic most prescribed and captured in stewardship program is the watch group, which we discussed earlier, that contain the most of the antibiotics with a broad spectrum and the reasoning for the antimicrobial resistance, like carbapenems, vancomycin, and piperacillin tazobactams. So most cases are done in the watch group. The reserve group is the auto ID consult, and our primary teams of other than the ID teams, they are also helpful for the stewardship program as a team effort in the institutions. They are not frequently prescribing that one. If it is prescribed, then it's an auto ID consult, then the ID is going to follow that. So we put only 6 cases we captured in last 2 months to practice as a reserve group. And what's the impact of this prospective audit and feedback? The ID consult increased by 2 times, like supposed to be per 100 cases on antibiotic in the hospital, the ID was consulted 30%, now increased by 60%. And also for this one, in 2 month data, we saved the more than 600 doses and more than 0.65 million cost saved. What could be the, because as we know, the antimicrobial stewardship is the best goal to control the antimicrobial resistance in the institutions. What could be the outcomes to achieve further? Improving patient care by optimal therapy, reducing collateral damage, यानी कि less toxicity, line infection of a length of stay, decrease the length of stay, to reduce the antimicrobial use, less resistance. The third, impact of the financial pharmacoeconomic considerations. It's not the short-term project, but it's a long-term which can be outcome can be seen in the years. It is start from the days and up to long-term in years. Thank you very much.
Thank you so much, Dr. Mujahid. It was surely an informative session, and we'll continue the Q&A session at the end. I have an important announcement for all my viewers. If you want CME certificate, so kindly fill the feedback form. Thank you.
Assalamu alaikum.
Moving on, continuing this program with another informative session by Dr. Abdul Manan. He's a registered pharmacist under Saudi Commission of Health Specialties and Pakistan Pharmacy Council Sindh. Currently, he is working as Deputy Manager Pharmacy Services at DHQ Hospital Badin, managed by Indus Hospital and Health Network. His career is spanned over 11 years in pharmaceutical services. He has held various clinical and administrative positions at Al Khidmat Hospital, Children Cancer Hospital, Al Musawwad Hospital, and the Indus Hospital and Health Network. Dr. Abdul Manan completed his PharmD from University of St. Jamshoro, followed by Master's degree in Management from University of St. Jamshoro and Antibiotics Towards Certificate from Health Sciences and Safety Institute, Notting Hill College, UK. He has been awarded as a champion pharmacist at Children Cancer Hospital, and his active participation for reporting medication errors during clinical activities at Al Musawwad Hospital.
I am Abdul Manan, Deputy Manager Pharmacy Services, DHQ Hospital, Badin, which is being managed by Indus Hospital and Health Network. Today we will be discussing introduction to Indus Hospital, Badin, their pharmacy services, challenges we faced in the implementation of pharmacy services, and our achievements, our pharmacy committees, training and development, future goals. Indus Hospital and Health Network is working with the government of Sindh public-private partnership since 2016. When Indus Hospital unanimously pledged their support to make difference to the disadvantaged communities in Badin, establishing and maintaining the country's best state-of-art paperless and 100% cashless secondary care hospital, where all medical services, including highly and surgical procedures, are not only provided indiscriminately to anyone in need, but were rendered absolutely free of cost with dignity as well. These are the specialties we are covering at Indus Hospital, DHQ Badin. Some specialties we are not covering, like ICU, neurosurgeries, which are in the plan for the future development. Department of Pharmacy Services. The hospital pharmacy is an integrated part of the patient healthcare in healthcare facility. The goal of pharmacy is to meet the primary care needed for the patient by fulfilling their responsibilities to provide pharmaceutical care, safe and effective use of choosing, preparing, storing, dispensing of medications and medical devices. We have pharmacy services, inpatient pharmacy, which is working 24 hourly, clinical pharmacy services, which is 9 to 5, emergency pharmacy services, 24 hourly, ambulatory OPD pharmacies. We have two OPD pharmacies working 8 a.m. to 5 p.m. Medic Surge sub-store we have, which is working 24 hourly, and warehouse, medical warehouse, which is working 8 to 5 p.m. This is our pharmacy organogram. In the department of pharmacy services, we have medical store, clinical pharmacy services, inpatient, ambulatory. And previously, as we started in 2016, we don't have any pharmacist in any of the locations, and even we don't have separate locations. Only one store was available from where they were dispensing for the inpatient, at outpatient, emergency, and for all the flow stock of the wards. But currently we have locations, 5 locations we have in the hospital pharmacy services, and everyone having the pharmacist. Like inpatient pharmacy, we have pharmacist, medical store also we have pharmacist, pharmacy technicians, pharmacy assistant, which are helping as a team for every dispensing of the medication and disposable services. Challenges we faced in the development of pharmacy services in 2016. There was unremarkable acceptance for the pharmacist, and there was unremarkable acceptance for the interventions. Pharmacists could not intervene in the prescription of any physician. There was unremarkable acceptance for the drug information services. There was a lot of polypharmacies, multi-drug therapies being prescribed by physicians at OPD and inpatient services. Unremarkable formulary management, whatever they wanted, they were prescribing and utilizing the medications. Manual prescriptions were being utilized in the hospital. Obstacles in HMIS implementation. When 2016 we have started with the HMIS, but it took time to implement fully the to remove the manual system. After implementation, we have some achievements. We have a cost-effective analysis ongoing process. Monthly, we are analyzing and displaying in the formulary committee and antibiotic stewardship committee, and being submitted to the head office pharmacy and therapeutic committee. We ensure rational use of medications, establishment of antibiotic stewardship committee. We have established a hospital formulary committee. Also, we have established the hospital formulary in our hospital. Introduction and implementation of clinical pharmacy services, and reward and recognition for our staff as employee of the quarter. You can see this was the Badin medical store previously. Uh, there was no proper arrangement, there was no storage, there was no any arrangement of the classical classification of the pharmacological or disposable separation, and no storage for the temperature monitoring. Currently, we have separate storage for every class of the medication, and also all the refrigerators for the room temperature is separate and refrigerator temperature is separate. Challenges we faced in the medical store, there was improper storage, there was unremarkable training for the staff regarding the policies and HMIS, improper dispensing of the medications and disposable items, lack of inventory monitoring, lack of near expiry and dead stock monitoring, cost effective analysis, batch wise issuance of medications, and disposable as per FIFO. But currently, we have overcome all these challenges, and we are working with the successfully. We are working proper storage with the proper temperature monitoring, proper monitoring of near expiry and data stock, and cost-effective analysis and issuance of medications and disposable as per batch and expiry. This is the look of pharmacy before Indus Hospital implementation. This is the current look of the pharmacy. Now we have separated all the high alert medications, and we have separated with the labeling auxiliary labels with the high alert and look-alike sound-alike medications. Disposable are being separated, injections, disposable, and all the classes of medications are being separated and dispensing as per their requirement through the HMIs. Same some challenges we have faced in the pharmacy implementation. There was manual prescriptions. There was uh, pharmacy was receiving the request on manual system. There was no HMIs records. So improper storage of the medication, as you see in the previous picture, and lack of rabies management. There was no any rabies management available at DHQ hospital. But since 2016, we never lack from the rabies therapy, even the uh, rabies immunoglobulin or rabies vaccine, and proper record we have since 2016. See the before Indus Hospital, the inpatient look, and after the Indus Hospital implementation, we have separated all the medications as per class, and we are dispensing the medications of inpatient pharmacy as per FIFO, and with the auxiliary labels. There is no any manual prescriptions, and all the entries are being entertained with the HMIS record. This is the label of our inpatient pharmacy services. You may see there is name of the patient, there is MR number of the patient, date of being dispensed, the drug name with the strength, the generic name of that product, dose, frequency, route of administration, if volume and dilution required for the IV injections, and parental medications, batch number of that particular medication, expiry of that medication, quantity of being dispensed, location for which ward are being dispensed, and the bed number prescribed by and the user who dispensed this medication, for double checking that if there is any near miss medication errors to control and overcome on the adverse drug reactions. Auxiliary labels, there was no concept previously, but we have implemented these all auxiliary labels that for the higher light medications, for look-alike, sound-alike medications, protect from light, refrigerator, and uh, for the external use. Outpatient pharmacy, this was the previous look we had, and this is the current look we have. So we are dispensing all the medications through proper system, and the same label will have the some information, the patient MR number, name, item, medication name with the strength, and also the generic name, dose, frequency, route of administration, duration, and quantity being dispensed, and the expiry of that medication. Also, it contains directions, medication dispensed by and prepared by. The challenges we had the same: manual prescriptions, dispensing without HMIS record, improper storage, medication dispensing without any system, and lack of patient counseling. Currently, we are counseling all the patients which we are receiving, and we are dispensing the medications and for every indication. This is the MedSearch substore. Previously, there was no any scope, or there was no any option in the system. So we have started since 2016 MedSearch substore, which contain 4 technicians, 24-hour services. All the medical and surgical disposables are being distributed to all the admission patients. Clinical pharmacy services we have for where pharmacists having a great role implemented already. He is reviewing the patient profile, reconciling the medications, reviewing the drug allergies. He is reviewing the label, lab investigations, consultant notes, progress notes. Even pharmacists have their own notes for the uh, observations, clinical interventions, and any corrective action required. Monitoring RFIV fluids, making interventions around with the consultant, providing drug information, continuous medication education, nursing education, flows of audit, and after crash volume. Challenges we faced: there was no concept of dosage adjustment. for the liver failure, have a hepatic failure, renal failure, or renal impairment. There was no concept of investigation required for the medication monitoring, like phenytoin aminoglycoside. Neurotherapeutic drug and medications need their therapeutic level monitoring. Vancomycin is there also. Utilization of medication without evidence-based indication. We have irrational use of antibiotics previously, absence of antibiotic stewardship committee, lack of pharmacist and physician clinical rounds, improper use of surgical prophylaxis antibiotics. There was no concept of IV to oral switch medications, ineffective role of post antibiotic effects. But currently, we have overcome all these uh, challenges, and we have successfully implemented the dose adjustment in the clinical pharmacy services. And now they are following proper investigations, and they are following rational use of antibiotics and all the medications. And they even implemented the antibiotic stewardship committee. We have pharmacist clinical rounds on daily basis. There's proper surgical prophylaxis antibiotics implementation and IV to oral switch implementation also. CME is also the part of the clinical pharmacy services. We are conducting at least 4 to 5 CMEs per month for the pharmacy services, and the same 4 to 5 CMEs we are being conducted for the all medical and allied healthcare staff, in which different topics are being selected and we are being presented at seminar hall. Also, the participation of pharmacy technicians in the CMEs, they are also conducting the CMEs weekly basis. We have pharmacy committees. First one is pharmacy committee, which is a campus-based committee, and being reported to the in the head office to the pharmacy and therapeutic committee. This pharmacy committee is responsible to evaluate all the medication dispensing errors, medications and dispensing analysis for effective utilization review, and medication addition or deletion or formulary review. Formulary is being reviewed annually. Also, we have antibiotic stewardship committee, who is responsible to review the antibiotic consumption as per cost, as per DDD values or DOT, days of therapy values, and CS based therapy, empirical, therapeutical, and prophylactic antibiotic for the surgical. Also, we have product evaluation and standardization committee, who is responsible to evaluate the product which are being start at our campus level, and the recommendations will be sent to the head office, and pharmacy and therapeutic committee will be presented. Antibiotic stewardship committee, the pharmacist having some responsibility to promote optimal use of antimicrobial agents, promoting the selection of optimal antimicrobial drug regimen, with reducing the transmission of infections, educate, educating the health professionals, patients, and public. Monitoring the presenting DDD and DOT. I will present the detail of daily defined doses and days of therapy in next slides. Also, pharmacists have round with the antimicrobial stewardship committee on daily basis. We have implemented first generation cephalosporins of for surgical prophylaxis antibiotics by reducing the third generation cephalosporins of surgical, since we have started the hospital. Daily defined dose, the assumed average maintenance dose per day for a drug used for its main indication in adult. Drug consumption can be expressed in cost, number of units, vials, number of prescriptions. Patient days or admission days are patient admitted for such duration in hospital. Antibiotic days are days of therapy, DOT. Duration of antibiotics for such duration, each antibiotic day will counted separately. This is the data we have collected from WHO website, who's responsible up to update their DDD values after 3 years. These are some example of DDD values which we are being monitoring. There was no concept previously to implement the IV to oral switch. Initially, we have selected all the applicable antibiotics from IV to oral switch. Then also we have selected some other medications like paracetamol, omeprazole, and metronidazole, which are well controlled in our hospital. Then we have training program for pharmacists, 2 week orientation and clerkship training of for pharmacy undergraduates are started already. Weekly departmental CMEs are being conducted for the pharmacy services and also allied healthcare staff. Weekly CME sessions for physician and nursing team. Current challenges of pharmacy services we have lack of sterile and non-sterile compounding areas, high turnover of pharmacy staff, lack of ADR reporting, lack of separate area of for patient counseling, delay in supplies and medication for and medical devices due to remote area, price increment, and pandemic. Delay in payment of the funds from the central government. Our future goals are we are developing professional development for the and we will get board certification of pharmacy specialties for all our pharmacy staff, and we will develop the sterile and non-sterile compounding. We will develop the barcode system for our pharmacy services. We will develop the dedicated drug area for the information center, and 1 year pharmacy residency program will be started. Pharmacy automatic devices will be included in our pharmacy services. Thank you.
Thank you so much, Dr. Abdul Manan. Critically ill patients are at obvious risk of contracting opportunistic infections from their immediate surroundings. Moreover, being in debilitating agony, their nutritional needs must also met with the safest and highest quality operations that ensure that such patients get the best healthcare. Regarding this, our next session is on total parenteral nutrition in ICU patients. And for that, I'd like to call our next speaker, Dr. Aisha Hanif. She is currently working as a senior clinical pharmacist oncology. She is an enthusiastic, self motivated, and experienced doctor of pharmacy, graduated from Dow University with a proven track record of leading oncology and sterile compounding, with over 7 years' experience in hospital pharmacy. She also has done ASHP critical care course and plays a vital part in IHHN. So please welcome Dr. Aisha. Dr. Aisha, you are not audible.
Yes, no.
Yes.
So
Thank you.
sorry for the instruction. Thank you, Rabika, for the introduction. Today, my topic of presentation is TPN in ICU patients. Is it visible? Okay. Today, I will answer some questions which are frequently asked about the role of TPN in critically ill patients. सबसे पहले तो जो सवाल आ जाता है कि हम क्रिटिकली इल पेशेंट में टीपीएन क्यों देना चाहिए है, क्यों ज़रूरी है, और जब टीपीएन स्टार्ट करना हो तो कब स्टार्ट करना है, और क्या ऑप्टिमल टाइम ड्यूरेशन है जिसमें टीपीएन जो है वो स्टार्ट कर देना चाहिए पेशेंट को। तीसरा, कितने ऑप्टिमल कैलोरीज रिक्वायर्ड होती हैं जब एक पेशेंट अगर आईसीयू या वेंटिलेटेड पेशेंट्स हैं, उनमें क्या रिक्वायरमेंट है ऑप्टिमल। इसके अलावा क्या कॉम्प्लिकेशंस एसोसिएटेड होती हैं जब पेशेंट को हम टोटल पैरेंटल थेरेपी पे स्विच करते हैं। वाई TPN इन क्रिटिकल इल पेशेंट्स, ड्यूरिंग जब पेशेंट मेटाबॉलिक डिस्ट्रेस में होता है और क्रिटिकल इलनेस में होता है तो उससे डिफरेंट मेटाबॉलिक चेंजेस हो रही होती हैं बॉडीज़ में, जिसमें फॉर एग्जांपल प्रोटीन कैटाबॉलिज्म इंक्रीज़ हो जाता है, जिसकी वजह से जो बेसल मेटाबॉलिक रेट है पेशेंट का वो अप टू 40% इंक्रीज़ हो जाता है। कुछ पेशेंट्स में इंसुलिन रेजिस्टेंस डेवलप हो जाती है, और जो सबसे लैग हो रही है
Screen.
क्यों नहीं हुई। Okay.
Dr. Aisha, you are visible. You can start.
Did you allow me to share my screen?
Yes, we do have.
Is it visible?
No, your screen is not visible.
I have shared, but it's not opening.
Yes, it's visible now.
Okay.
Yes, Dr. Aisha, we can see your screen.
Okay. Some of the I will discuss some of the important questions related to TPN कि हमें जब एक पेशेंट क्रिटिकली इल पेशेंट होता है आईसीयू में एडमिट होता है पेशेंट तो उस क्यों उस पेशेंट के लिए टीपीएन ज़रूरी है और किस टाइम पे या किस वक्त जो है वो टीपीएन स्टार्ट करना चाहिए कितनी कैलोरीज रिक्वायर्ड होती हैं एक पेशेंट के लिए ऑप्टिमल कैलोरीज जो पेशेंट आईसीयू में है वेंटिलेटेड है या व्हाटसोएवर मेटाबॉलिक डिस्ट्रेस में है इसके अलावा हम क्या कॉम्प्लिकेशन हमें फेस करनी पड़ती हैं जब टीपीएन पे पेशेंट को स्विच करते हैं why TPN in critically ill patients during critical illness profound metabolic changes जब पेशेंट जब क्रिटिकल इल होता है तो उसके बहुत ज़्यादा जो मेटाबॉलिक डिस्ट्रेस में होता है उसकी वजह से डिफरेंट जो है वो ऑर्गन डिसफंक्शन हो जाते हैं फॉर एग्जांपल प्रोटीन कैटाबॉलिज्म डिस्टर्ब होता है जिसमें जो है वो मेटाबॉलिक रेट जो है वो बेसिक मेटाबॉलिक रेट अप टू 40% बढ़ जाता है इसके अलावा कुछ पेशेंट्स में इंसुलिन रेजिस्टेंस डेवलप हो जाती है और जो सबसे ज़्यादा वर्ल्ड वाइड एक जो पॉइंट ऑफ कंसर्न है वो है मैल न्यूट्रिशन स्टारवेशन यानी अगर पेशेंट प्रोलॉन्ग एडमिशन है मोर देन 5 days और 7 days और तो वो वहाँ पे पेशेंट ऑलरेडी अगर एक तो पेशेंट मैल नरिश है या फिर उसका ओरल इंटेक बिल्कुल ही बंद है तो उस कंडीशन में फिर पेशेंट जो है वो उनका इम्यून सिस्टम इम्पेयर्ड हो जाता है मसल वीकनेस हो जाती है जिसमें अल्टीमेटली पेशेंट जो है वो अल्टीमेटली ऑर्गन डिसफंक्शन सिवियर कॉम्प्लिकेशंस इन्फेक्शंस हो जाते हैं पेशेंट्स को जिसकी वजह से पेशेंट का लेंथ ऑफ स्टे जो है हॉस्पिटल में वो बढ़ जाता है Why TPN in critically ill patient? Patient should be fed क्योंकि different guidelines है different guidelines की different recommendations हैं कि it's better कि patient को आप TPN start कर दें बजाय इसके कि पेशेंट को अंडर फीड रखें और स्टार्व रखें तो उससे पेशेंट की जो मॉर्बिडिटी और मोर्टेलिटी के जो चांसेस हैं वो बहुत ज़्यादा बढ़ जाते हैं और डिफरेंट स्टडीज़ में ये बताया गया है कि जिन पेशेंट्स को सिंपल ग्लूकोज दिया गया या फिर जो है वो टीपीएन इनिशिएट किया गया तो जिन पेशेंट्स को टीपीएन इनिशिएट किया गया था उसमें मोर्टेलिटी रेट जो है वो कम है स्क्रीन शेयर करें स्क्रीन शेयर करें स्टडीज़ डिफरेंट स्टडीज़ में ये शो किया गया है कि जो है वो टीपीएन इनिशिएट करने के बाद मोर्टेलिटी रेट कुछ हद तक कम हुआ है
Excuse me, sorry to interrupt you. And Dr. Aisha, please tap F5, please, in order to bigger your screen. The words aren't visible. Your slide is not visible. Press F5.
My slide was visible. Something happened in between. What issue?
Dr. Aisha, PowerPoint पे click कीजिए आप पहले and then press 5, F5. I'm sorry, there's a miscommunication. Dr. Aisha has left. We are trying to reconnect with her. And she is live again. Sorry to interrupt everyone. Dr. Aisha, you can start.
Because it's visible now?
Yes, it is visible. Your slides are visible.
Okay, thank you. एक्यूट पेशेंट व्हेन पेशेंट इज एन एक्यूट इलनेस, तो हमारा टारगेट होता है कि जो है मैक्सिमम जो है जो मेजर्ड एनर्जी एक्सपेंडिचर रिक्वायर्ड है वो पेशेंट को हम प्रोवाइड करें, ताकि जो पेशेंट नेगेटिव एनर्जी बैलेंस में जा रहा है उसको हम अवॉइड कर सकें। अच्छा, टीपीएन कब स्टार्ट करना चाहिए, इसके बारे में डिफरेंट गाइडलाइंस, डिफरेंट रिकमेंडेशंस देती हैं। जैसे फॉर एग्जांपल यूरोपियन सोसाइटी ऑफ पेरेंटल एंड इंटर न्यूट्रिशन गाइडलाइंस वो रिकमेंड करते हैं कि एटलीस्ट 2 to 3 डेज में जो है वो पेशेंट को असेस करना लाजमी है कि पेशेंट की न्यूट्रिशनल नीड पूरी हो रही है या नहीं। अगर नहीं हो रही तो विद इन 24 to 48 आवर्स में एटलीस्ट इंटरनल न्यूट्रिशन स्टार्ट हो जानी चाहिए। और अगर इंटरनल न्यूट्रिशन किसी भी वजह से पेशेंट का गट फंक्शन नहीं कर रहा या पेशेंट टॉलरेट नहीं कर पा रहा, तो उस सूरत में या कोई कॉन्ट्राइंडिकेशन है, तो उस सूरत में फिर पेरेंटल न्यूट्रिशन पे स्विच किया जाए। जिसके अलावा एएसपीएन रिकमेंड करते हैं कि फॉर ईएन जो उनका प्राइमरी कंसर्न है या प्राइमरी उनकी जो रिकमेंडेशन है वो ये है कि पेशेंट को इंटरनल न्यूट्रिशन पे स्टार्ट किया जाए। पेशेंट के गट फंक्शन को मेंटेन करना भी इम्पॉर्टेंट है, और वो रिकमेंड नहीं करते कि एटलीस्ट 7 डेज ऑफ हॉस्पिटलाइजेशन, जब पेशेंट 7 डेज ऑफ हॉस्पिटलाइजेशन के बाद पीएन इनिशिएट करे, ना कि उससे पहले। उससे पहले कोशिश करनी चाहिए कि वो इंटरनल फीड पे जो है पेशेंट को मेंटेन रखें। इसके अलावा नेशनल इंस्टीट्यूट फॉर हेल्थ एंड क्लिनिकल एक्सेलेंस रिकमेंड करते हैं कि आप अगेन यहाँ पे पेशेंट का मैलनरिश स्टेटस जो है वो असेस करना बहुत ज़रूरी है कि पेशेंट अगर लीन वेट है, पेशेंट का इनटेक नहीं है, या कोई अनइंटेंशनल वेट लॉस हो रहा है किसी भी रीज़न की वजह से, तो वो जो है वो लॉसेस को ओवरकम करने के लिए रिस्क वर्सेस बेनिफिट वाली बात है कि आया पेशेंट को ये पीएन देना ज़्यादा ज़रूरी है या पेशेंट को जो है वो ऑब्जर्व के पेशेंट को पीएन डिले करना ज़्यादा बेहतर है या पीएन अर्ली स्टार्ट करना ज़्यादा बेहतर है। तो दिस इज़ ऑल अपॉन क्लिनिशियन के वो उसका असेसमेंट कितना जो है वो इम्पॉर्टेंट है। न्यूट्रिशन की असेसमेंट किस तरह होती है कि डिफरेंट आपको आप जब न्यूट्रिशन असेसमेंट करने जाते हैं तो डिफरेंट मेथड्स आते हैं। फॉर एग्जांपल इनडायरेक्ट कैलोरीमेट्री मेथड्स है, डिफरेंट इक्वेशंस हैं, बेनेडिक्ट इक्वेशंस यूज होती हैं, जिसमें जो है वो एक एस्टिमेटेड बेसल एनर्जी और टोटल एनर्जी एक्सपेंडिचर कैलकुलेट होता है। बट क्योंकि प्रैक्टिकली समटाइम्स ऐसा भी होता है कि पेशेंट का जो है वो बेड रिडन पेशेंट होते हैं, बेड पे होते हैं, इक्वेशंस जो है समटाइम्स ऐसा भी होता है कि वो ओवर एस्टिमेशन या अंडर एस्टिमेट भी कर देती है एनर्जी रिक्वायरमेंट, क्योंकि उसमें एक्टिविटी फैक्टर, रिस्क फैक्टर, वो सारी चीज़ें इन्वॉल्व होती हैं। तो उस चीज़ को अवॉइड करने के लिए वो कहते हैं कि इन द एब्सेंस ऑफ दीज मैथड वो आप जो है वो 20 to 25 किलो कैलोरीज पर केजी पर डे से इनिशिएट करें, और जो है वो ग्रेजुअली आप अप टू 35 किलो कैलोरीज पर केजी पर डे तक भी दे सकते हैं पेशेंट को। रूट्स कौन से हैं? सबसे जो आईसीयू पेशेंट में जो सबसे इम्पॉर्टेंट चीज़ है कि एक कंप्लीट बैलेंस फॉर्मुलेशन प्रोवाइड करना बहुत ज़रूरी है। और जो है वो यहाँ पे हम लिमिटेशंस आ जाती हैं एक्सेस की, एडमिनिस्ट्रेशन एक्सेस दो तरह के होते हैं, या तो सेंट्रल वेनस एक्सेस डिवाइस से टीपीएन को दिया जाए या फिर जो है पेरिफेरल लाइन से दिया जाए। अब यहाँ पे जो है पेरिफेरल लाइन में कुछ लिमिटेशंस होती हैं ऑस्मोलैरिटी की और कंसंट्रेशन की, क्योंकि जितनी ज़्यादा कंसंट्रेशन होगी टीपीएन की उतनी ही ज़्यादा जो है वो जितनी ज़्यादा कंसंट्रेशन होगी उतनी ज़्यादा ऑस्मोलैरिटी होगी। लेकिन पेरिफेरल एक्सेस में लिमिटेशन है कि आप सिर्फ लो ऑस्मोलैरिटी मिक्सचर्स दे सकते हैं जिसकी ऑस्मोलैरिटी अराउंड 900 मिली ऑस्मोल पर लीटर से कम हो। इससे ज़्यादा अगर आप देंगे तो फ्लेबाइटर्स और इन्फ्लेमेशन के चांसेस बढ़ जाते हैं। तो उस चीज़ को ओवरकम करने के लिए सेंट्रल वेनस डिफरेंट गाइडलाइन रिकमेंड करते हैं। सेंट्रल वेनस जो एक्सेस है वो प्रेफर्ड है, पिक लाइन हो गई या कैथेटर्स हो गए, तो उससे आप एडमिनिस्टर करें, और उसमें ऑस्मोलैरिटी की रेंज और जो है कंसंट्रेशन बहुत ज़्यादा होती है। जब कंसंट्रेशन आप ज़्यादा देते हैं तो एनर्जी रिक्वायरमेंट जो है वो ज़्यादा फुली हम पेशेंट की पूरी कर सकते हैं। कंपोनेंट्स कौन कौन से होते हैं? सबसे मेन कंपोनेंट्स है हमारे पास कार्बोहाइड्रेट, जो सबसे ज़्यादा जो है एनर्जी सोर्स है, अराउंड जो है वो मोर देन 50% जो है वो एक आप कह सकते हैं कि टीपीएन में एनर्जी सोर्स इसको दे सकते हैं. द मिनिमल अमाउंट ऑफ कार्बोहाइड्रेट रिक्वायर्स अबाउट 2 ग्राम ऑफ ग्लूकोज पर डे. दिस इज द मिनिमल. अब इट डिपेंड्स कि आप पेशेंट की रिक्वायरमेंट क्या है, कम है, ज़्यादा है, हाइपरग्लाइसीमिया का चांस तो नहीं है. तो इट डिपेंड्स, वेरियस फैक्टर्स इन्वॉल्व होते हैं डोजिंग के लिए भी, लेकिन जो रिकमेंडेड डोज है वो ये है कि वो 2 ग्राम पर केजी ऑफ ग्लूकोज पर डे दें. इसमें देखा गया है कि जिन पेशेंट्स का ग्लूकोज लेवल जो है वो अराउंड 80 to 110 मिलीग्राम पर डेसीलीटर तक अगर मेंटेन रखें तो उसमें जो है मोर्टालिटी रेट्स रिड्यूस हुए हैं. और जबकि अगर पेशेंट सिवियर हाइपरग्लाइसीमिया में अगर गए हैं तो वो पेशेंट के लिए लीथल, पेशेंट एक्सपायर भी हुए हैं, डिफरेंट डेथ्स रिपोर्ट हुई हैं. और जितना ज़्यादा हाइपरग्लाइसीमिया होगा पेशेंट ज़्यादा रिस्क पे चला जाएगा इन्फेक्शंस के. तो ये भी एक फैक्टर है कि हाइपरग्लाइसीमिया को कंट्रोल करना और इन्फेक्शन को कंट्रोल करना भी एक इम्पॉर्टेंट फैक्टर है. इसके अलावा प्रोटीन है. प्रोटीन देने का मेन गोल यही है कि क्रिटिकल इलनेस में जो प्रोटीन सिंथेसिस के जो प्रीकर्सर्स होते हैं वो प्रोवाइड करना, ताकि जो है वो टिश्यूज़ में जो ब्रेक डाउन हो रहा है, हाई टर्नओवर है, उसको प्रिवेंट कर सकें, स्केलेटल मसल को के फंक्शंस को और मसल मास को प्रिवेंट कर सकें. तो जो सिवियरली उसकी जो रिकमेंडेड डोज है वो अप्रॉक्सीमेटली 1.3 to 1.5 ग्राम पर केजी आइडियल बॉडी वेट पर डे इन कंजुगेशन विद एन एडिक्वेट एनर्जी सप्लाई. अब जितना ज़्यादा पेशेंट अगर स्ट्रेस में है आप उतना ज़्यादा हायर डोज की तरफ जा सकते हैं, बट मिनिमम डोज रेंज यही है क्रिटिकल इल पेशेंट में कि 1.3 to 1.5 ग्राम पर केजी पर डे दें. इसके अलावा लिपिड्स हैं. लिपिड शुड बी एन इंटीग्रल पार्ट ऑफ पीएन फॉर एनर्जी एंड टू इंश्योर एसेंशियल फैटी एसिड प्रोविजन इन लॉन्ग टर्म. जिन पेशेंट्स को जो है वो लॉन्ग टर्म जो स्टे पेशेंट्स उनके लिए भी लिपिड जो है वो एक कैलोरीज में जो है सबसे ज़्यादा जो है कंट्रीब्यूट करता है, जिसकी वजह से जो ये भी एक इम्पॉर्टेंट पार्ट होता है टीपीएन कंपोनेंट का. इंट्रावेनस लिपिड इमल्जन्स जो है कैन बी एडमिनिस्टर्ड सेफली एट अ रेट ऑफ 0.7 ग्राम पर केजी टू अप टू 1.5 ग्राम पर केजी ओवर 12 to 24 आवर्स. ये अब जो है डिफरेंट टाइप्स के टीपीएन होते हैं, 2 in 1 होते हैं, 3 in 1 होते हैं. तो लिपिड्स जो है सेपरेटली भी इन्फ्यूज़ किए जा सकते हैं और ऑल इन वन 3 in 1 बैग में भी दिया जा सकता है. एक और जो हमारे जो एक और चीज़ें जो अक्सर कंसिडर नहीं हो पाती कि लिपिड इमल्जन जो कैलोरी कंट्रीब्यूट कर रहे होते हैं और पेशेंट जो आईसीयू में होते हैं अक्सर सेडेशन पे होते हैं. अगर फॉर एग्जांपल प्रोपोफोल चल रहा है तो प्रोपोफोल भी इस टाइप ऑफ इमल्जन और उसका भी एक कैलोरी, अगर हाई कंसनट्रेशन में प्रोपोफोल चल रहा है तो डैट मीन्स वो भी कुछ ना कुछ कैलोरीज में कंट्रीब्यूट कर रहा होगा. इट प्रोवाइड्स फैट्स 1.1 किलो कैलोरीज पर ml ऑफ फैट. तो जब भी फाइनल लिपिड कॉन्सेंट्रेशन या लिपिड कैलकुलेशन होगी तो पेशेंट अगर प्रोपोफोल थेरेपी पे तो उसका जो है वो टोटल भी उसमें कंट्रीब्यूट होगा.
Dr. Aisha, is there any issue?
Shafiq said that my slides are not visible.
It is visible now.
Okay, next part is electrolytes. इलेक्ट्रोलाइट्स जब भी हम पेशेंट्स के जो इनिशियल बेसलाइन लैब्स करवाते हैं, जब भी टीपीएन इनिशिएट करते हैं तो पूरा एक बेसलाइन पैनल इलेक्ट्रोलाइट्स का करवाना बहुत ज़रूरी है. और जो इलेक्ट्रोलाइट्स की जब डोजिंग कंसंट्रेशन जब हम डोजिंग करने जाते हैं टीपीएन में तो ये चीज़ें बहुत मैटर करती है, बिकॉज हमें पेशेंट के जो लैब नंबर्स को ट्रीट नहीं करना, बेसिकली पेशेंट की अंडरलाइंग कॉज को ट्रीट करना है. तो जब भी आप इलेक्ट्रोलाइट डिसऑर्डर्स पे फोकस करें तो ये देखें कि वो एक्यूट कंडीशन है या क्रॉनिक कंडीशन है। एक्यूट में आप यू कैन नॉट प्रिडिक्ट कि हाउ पेशेंट विल रिएक्ट नेक्स्ट, बट क्रॉनिक में जो कंसिस्टेंटली लोअर लेवल्स होते हैं तो उसमें आप थोड़ा मैक्सिमम या ज़्यादा कंसनट्रेशन ऑफ इलेक्ट्रोलाइट दे सकते हैं। सिम्टोमेटिक है या नहीं है और किस रीज़न की वजह से है, अगर तो वो और अगर इमीडिएट रिप्लेसमेंट की नीड है तो टीपीएन इज़ नॉट द सोर्स फॉर द इमीडिएट करेक्शन। सो ये सारे फैक्टर्स को कंसिडर करना ज़रूरी है। और अगर पीएन इनिशिएट करने से पहले इलेक्ट्रोलाइट एबनॉर्मलिटीज़ और करेक्शन करना बहुत ज़रूरी है, स्पेसिफिकली वो अगर पेशेंट सिम्टोमेटिक हैं तो। अवॉइड रिप्लेसिंग इलेक्ट्रोलाइट डेफिशिएंसी यूजिंग पीएन इन एक्यूटली इल पेशेंट्स, और अगर रीनल फंक्शन इम्पेयर्ड है तो डिफरेंट रिकमेंडेशन है कि आप या तो लोअर डोज से स्टार्ट करें या 50% ऑफ रिकमेंडेड डोज है। लोअर डोज से देना इज सेफ, बजाय इसके कि आप हायर कंसंट्रेशन पे दें और पेशेंट को है वो सडन शिफ्ट हो और फ़ायदे की बजाय नुकसान हो पेशेंट के लिए, वो जो है वो लोअर डोज देना इज़ गुड बेटर देन एक्सेस। ओबीस पेशेंट के लिए आइडियल बॉडी वेट से जो है वो कैलकुलेट डोजिंग कैलकुलेट होगी। ये भी देखना ज़रूरी है कि पेशेंट को सिर्फ एक डिसऑर्डर है या मल्टीपल डिसऑर्डर्स है, कोमॉर्बिड कंडीशंस देखना ज़रूरी है। एज रिलेटेड चेंजेस हो सकती हैं। ये कुछ रिकमेंडेड डोजिंग है इलेक्ट्रोलाइट्स की जो कि पीडियाट्रिक है, देन अडल्ट पेशेंट है। तो ये डोज रेंज है, इन्हीं डोज रेंज में रहते हुए हम जो है वो टीपीएन में डोजिंग इनकॉर्पोरेट करते हैं। इसके अलावा मल्टीवाइटामिन्स है। मल्टीवाइटामिन्स जो है वो रिकमेंडेड डेली अमाउंट जो है वो उसकी बेसिस पे दिए जाते हैं, और डिफरेंट टाइप्स के जो मल्टीवाइटामिन है वो टीपीएन में एज पर नीड डाले जाते हैं। फॉर एग्जांपल बी कॉम्प्लेक्स है। बी कॉम्प्लेक्स एंजाइम जो होते हैं वो बहुत इंपॉर्टेंट होते हैं एनर्जी कन्वर्जन में। जो डिफरेंट हमारे बॉडी के जो मेटाबॉलिक प्रोसेसेस चल रहे होते हैं उसमें डिफरेंट को एंजाइम के तौर पे वो एक्ट कर रहे होते हैं, तो वो बी कॉम्प्लेक्स है। इसके अलावा स्कॉर्बिक एसिड है जो कि वूंड हीलिंग में हेल्प करता है। विटामिन ए जो है वो विजन और प्रोडक्शन ऑफ म्यूकस बोन ग्रोथ में हेल्प करता है। अभी न्यू रिकमेंडेशन आई हैं कि आप IV विटामिन डी भी ऐड कर सकते हैं जो कि कैल्शियम फॉस्फेट होम्योस्टैसिस और बोन कैल्सिफिकेशन को भी प्रिवेंट कर सकता है। तो इट ऑल डिपेंड्स कि पेशेंट की रिक्वायरमेंट क्या है, लैब वैल्यूज़ क्या है। तो और यूजुअली हमारे पास जो पाकिस्तान में प्रोडक्ट्स आते हैं वो कॉम्बिनेशन प्रोडक्ट्स आते हैं, तो हम जो है वो डोजिंग जो रिकमेंडेड डेली अमाउंट है उस डोजिंग रेंज में रहते हुए जो है वो हम पेशेंट को मल्टीविटामिन देते हैं। जब भी टीपीएन इनिशिएट करते हैं पेशेंट के लिए क्रिटिकल केयर में मॉनिटरिंग इज़ द की। सबसे इम्पॉर्टेंट है पेशेंट को डेली बेसिस पे मॉनिटर करना, और बेस लाइन वर्कअप बहुत ज़रूरी है, बिकॉज यू नेवर नो आईसीयू में जो पेशेंट है या क्रिटिकल एक्यूटली इल पेशेंट है उसकी मेटाबॉलिक कंडीशन किस तरह से कंडीशन वो डेवलप होती है या प्रोग्रेस होती है या बेटर होती है। तो ये मॉनिटरिंग बेस लाइन CBC होने चाहिए, ब्लड क्रिएटिनिन होना चाहिए, इलेक्ट्रोलाइट्स होने चाहिए। इसके अलावा इनिशिएशन के बाद एटलीस्ट 7 डेज फॉर 1 वीक तक फॉलोअप ज़रूरी है। फिर ये कुछ चीज़ें ऐसी हैं जो कि डेली बेसिस पे अगर क्रिटिकली इल पेशेंट है तो डेली बेसिस पे मॉनिटर करना बहुत ज़रूरी है, और उसी बेसिस पे जो है वो ख़ास तौर पे इलेक्ट्रोलाइट्स हैं, ग्लूकोज है, वो डेली बेसिस पे मॉनिटर करना ज़रूरी है। और अगर आप टीपीएन में इंसुलिन भी ऐड कर रहे हैं तो हर 2 आवर्स में जो है वो उसको ग्लूकोज मॉनिटर करना ज़रूरी है, क्योंकि पेशेंट सडन हाइपोग्लाइसीमिया में जा सकते हैं। पेरेंटल न्यूट्रिशन के 3 कॉम्प्लिकेशंस बहुत सारी हैं, क्योंकि अगर पेशेंट या तो कॉम्प्लिकेशन जो है वो 3 तरह की हो सकती हैं। मेटाबॉलिक हैं, इन्फेक्शन है या मैकेनिकल। मेटाबॉलिक में पेशेंट का हाइड्रेशन स्टेटस, फ्लूइड रिस्ट्रिक्शन है या नहीं है। अगर टीपीएन स्टार्ट इनिशिएट किया है तो जो पेशेंट को इसके अलावा फ्लूइड चल रहा है वो स्टेटस भी इंक्लूड होगा कि टीपीएन के अलावा कितना फ्लूइड उस पेशेंट को मिल रहा है, ओवर फ्लूइड तो नहीं है, अंडर फ्लूइड तो नहीं है, इलेक्ट्रोलाइट डिस्टर्बेंस, हाइपरग्लाइसीमिया, ये सारी चीज़ें मॉनिटर करना बहुत ज़रूरी है, अदरवाइज इट विल लीड टू मेटाबॉलिक डिस्ट्रेस। इसके अलावा कैथेटर रिलेटेड इन्फेक्शंस हो जाते हैं पेशेंट के, सेंट्रल लाइन इन्फेक्शंस जो है वो बहुत कॉमन है आईसीयू में। इसके अलावा मैकेनिकल, क्योंकि जो है हमारे पास अगर कैथेटर डिसलोकेट हो जाए या जो मैक्रोन्यूट्रिएंट्स होते हैं टीपीएन में उनकी कंसिस्टेंसी थिक होती है तो उसकी वजह से कभी कोई ऑक्लूजन भी हो सकता है, रप्चर भी हो सकता है, और इसके अलावा वेनस थ्रोम्बोसिस भी जो है वो कॉमन है। सबसे जो इम्पॉर्टेंट फिनोमेना है वो आईसीयू पेशेंट्स में जो है वो बहुत ज़्यादा कॉमनली देखा गया है, रीफीडिंग सिंड्रोम। जब टीपीएन इनिशिएट करते हैं, स्टार्ट करते हैं, तो उसमें हमें ये देखना होता है कि पेशेंट का इलेक्ट्रोलाइट पैनल क्या है। अगर पेशेंट सिवियरली मैलनरिश्ड है और इनटेक उसका बिल्कुल नहीं, और आप एकदम से हाई कंसंट्रेशन पे उसको फ्लूइड्स और जो है वो मैक्रोन्यूट्रिएंट्स और माइक्रोन्यूट्रिएंट्स इलेक्ट्रोलाइट्स अगर आप देंगे तो जो सडन बायो मेटाबॉलिक और फिजियोलॉजिकल शिफ्ट होगा मेरे सारे कंपोनेंट्स का, उसकी वजह से पेशेंट रीफीडिंग सिंड्रोम में चला जाता है। तो इस उस कंडीशन में फिर उस चीज़ को प्रिवेंट, फिर उसमें सारे आपके इलेक्ट्रोलाइट जो है वो डिक्रीज होना शुरू हो जाते हैं, पोटेशियम, मैग्नीशियम एंड फास्फोरस, और जो है वो उस कंडीशन में फिर जो है वो पेशेंट को टीपीएन फ़ायदे के बजाय नुकसान दे रहा होता है। तो कौन से पेशेंट हैं जो कि इस रिस्क पे होते हैं, जैसे मैल नरिश पेशेंट है, या पेशेंट का जो है वो बिल्कुल ही इनटेक नहीं है एक या एक वीक से ज़्यादा, और इसके अलावा सिवियर मेटाबॉलिक डिस्ट्रेस में है, तो क्लिनिशियन को असेस करना बहुत ज़रूरी है कि अगर मैं टीबीएन इनिशिएट करूँगा तो पेशेंट जो है वो रीफीडिंग सिंड्रोम में जाने के उसके कितने चांसेस है। और गट इसीलिए वो रिकमेंड करते हैं, जो डिफरेंट गाइडलाइंस है वो इसीलिए इंटेरल न्यूट्रिशन पे भी ज़्यादा फोकस इसीलिए करते हैं कि गट अगर फंक्शनिंग है तो गट्स को फंक्शनल रखने के लिए और जो है वो इंटेरल फीड या ओरल फीड पे पेशेंट को रखें, ताकि पेशेंट को अगर पीपीएन पे भी स्विच करना हो तो जब ट्रांजिशन के दौरान पेशेंट रीफीडिंग सिंड्रोम में ना जाए। सप्लीमेंटल टीपीएन भी पेशेंट्स को दिए जा सकते हैं। क्यों रीफीडिंग सिंड्रोम में इंट्यूबेटेड पेशेंट्स है अगर पेशेंट इंट्यूबेटेड है तो और भी ज़्यादा रिस्क है, क्योंकि उस कंडीशन में जो है वो अगर फॉर एग्जांपल सारा जो है इलेक्ट्रोलाइट पैनल डिक्रीज है, फॉस्फोरस भी डिक्रीज है, तो फॉस्फोरस जो है वो रोल प्ले करता है मसल वीकनेस कॉज करवाता है। तो इट इज़ विल बी डिफिकल्ट फॉर अ फिजिशियन टू एक्सट्यूबेट द पेशेंट, क्योंकि अगर मसल वीक है, पेशेंट अपने मसल को जो है वो यूज़ नहीं कर पा रहा, रिस्पायरेशन में उसको डिफ़िकल्टी है, तो डिक्रीज फॉस्फोरस की वजह से वो जो है वो जल्दी जो है वो वेंट से वीन ऑफ नहीं हो पाएगा। इसके अलावा जो है वो फॉस्फोरस का जो आपका बॉडी में मेटाबॉलिज्म है, एटीपी कन्वर्जन में भी उसका एक बहुत बड़ा रोल है। तो पेशेंट का रीफीडिंग सिंड्रोम की वजह से पेशेंट की लेंथ ऑफ स्टे और वेंटिलेशन टाइम जो है वो बढ़ जाता है। कॉम्प्लिकेशन में क्या, उन कॉम्प्लिकेशन से बचने के लिए सबसे ज़्यादा जो है वो क्या हम कर सकते हैं वो है कि स्ट्रिक्ट अप्रोप्रिएट ब्लड ग्लूकोज कंट्रोल करें, और जो है वो ऑलिव ऑयल, डिफरेंट स्टडीज़ रिकमेंड करती हैं कि ऑलिव ऑयल या फिश ऑयल बेस्ड जो है वो इमल्जन्स यूज़ किए जाएं, जो कि नॉर्मली हमारे पास जो अवेलेबल होते हैं वो सोयाबीन ऑयल बेस्ड वंस होते हैं, तो वो ज़्यादा जो है इम्यून सिस्टम को ज़्यादा स्ट्रॉन्ग करते हैं और पेशेंट को जल्दी रिकवर कराने में हेल्प करते हैं। द अडॉप्शन ऑफ इंसर्शन एंड केयर ओके स्ट्रिक्ट एसेप्टिक टेक्निक जो होती हैं पेशेंट की लाइन इंसर्ट करते वक्त, हैंडलिंग करते वक्त जो है वो ये बहुत ज़रूरी है कि स्ट्रिक्ट एसेप्टिक प्रोसीजर्स को फॉलो किया जाए, हैंड हाइजीन और इन सारी चीज़ों पे बहुत ज़्यादा फोकस होना चाहिए, और ऐसी पॉलिसीज़ इम्प्लीमेंट होनी चाहिए जो कि एरर्स को बिल्कुल मिनिमाइज कर सके। This is all from my side. Is there any question?
Thank you so much, Dr. Aisha. It was surely an informative session, and now we'll move to our question and answer session. But before that, I would like to remind to please fill your feedback forms. Thank you. The first question is from Dr. Sherif Kamal. I hope he is here. Dear sir, as learner, how to develop KPIs and in onco pharmacy.
So, hello everyone. Thank you very much for having me in your esteemed conference. You getting well?
Sorry to interrupt you, sir. Your voice is not audible.
Can you hear me now?
Yeah, I can hear you now.
Okay. Okay. So hello everyone. Thank you very much for this great conference. Being part of you is a great honor for me. And good morning from Cairo, Egypt. Hi, everyone. So you can hear well now?
I can hear you, but your voice is breaking. It's not clear.
Okay. So I will try to. So now it's clear. Now it's clear.
You're not audible, sir.
Now it's okay. So you can hear me now.
Yeah, I can hear you now.
Okay. Okay. So it is a very important question about the key performance indicator because like you cannot manage what you cannot measure and you cannot improve what you cannot measure. So key performance indicators are there to make and help you to identify how good you are working. So regarding oncology, the first step that you need to do to make a key performance indicators is that you identify what is your goal, what you want to make. So for example, for pharmacy and oncology, if you are doing clinical interventions, so you need to put, for example, a key performance indicator of a certain number of clinical interventions. Number two, if you are performing like the doctor was speaking about antimicrobials and in septic shock oncology patient, you need to deliver it in a timely manner. So if you put a key performance indicator for delivering that medication within a certain time, this is also a very important KPI that will measure your performance and it will affect the outcome. Also, you can have a key performance indicator if you are having a central IV admixture area. So you can have a key performance indicator regarding the percentage saving providing by central administration and admixture of the medication. If you are providing patient education service, so you have a key performance indicator, patient education and patient satisfaction. So there is a lot of key performance indicators that you can do. I can help you to make your key performance indicator that will measure your performance and improve your performance. My dear friend Dr. Arif have my all my contacts and we can be on Zooms together to identify our goals and to produce what we call key performance indicator catalog, and accordingly you can work. So anytime I'm available for you. Thank you.
Thank you so much, Dr. Sharif Kamal. Now, our second question is from Dr. Mujahid. What are the key factors that needs to be taken in account before choosing an appropriate antibiotic? This question is from Dr. Mujahid.
Thank you, Rabika. It is a very nice question to ask. As we discussed in our presentations, various aspects regarding the antimicrobial selection. One base word that I have given acronym, if you see, mind me approach, that you have to go with the microbiology based results that you have to select, and pharmacological basis that you have to see key factors is on a basis we can go with the stewardship program. Other than the stewardship program, we can go the nature of the drug. It means it's going to penetrate in the brain or not. Once you select if there's any meningitic case, if there's a penetration, there's this the drug that you are selecting for bacteremia, for example, it has a good serum concentration or no. These are some key factors that you select on that, like PKPD classification, that we nature of the drug, lipophilic, hydrophilic nature. These are some aspects that you have to considered in that. But in general, in a summarized form, we can say the whole stewardship program is the best tool to resolve all kind of questions in an antimicrobial use. in the institution. Thank you.
Thank you so much, Dr. Mujahid. And our next question is from Dr. Abdul Manan. Please share a little about the available facility of anti-snake venom and its outcome at DHQ Badin.
Thank you, Rebecca. Yes, we have facility for anti-snake venom and being administered and being prescribed at emergency and inpatient patients. About its highest consumption during the starting from the March and ending at September, and the quarterly about we have 1 million we are consuming on anti-snake venom due to this remote area of Badin. A lot of consumption we have it, and this is being prescribed and being monitored on the basis of PT, APTT, and BCT level of the patient, and then the next dose being decided to be administered or not to be administered. Thank you.
Thank you so much, Dr. Abdul Manan. And our very next question is, and last also, is from Dr. Aisha. Lipofundin, NA in pharmacy. How could we manage fat requirements in a better way?
यूजुअली इन आर सेटिंग हम जो है वो कॉम्पनसेट करने की कोशिश करते हैं पहले प्रोटीन्स और कार्बोहाइड्रेट से, बट अगेन लिमिटेशंस आ जाती हैं. फिर सेंट्रल लाइन से अगर आप देते हैं तो यू कैन ऐड मोर कंसंट्रेशन ऑफ डेक्सट्रोज एंड अमाइनो एसिड, तो कुछ हद तक तो कॉम्पनसेशन हो जाता है, बट अगेन वो फुली जो क्योंकि फैट एक कैलोरीज का एक मेजर पार्ट कंट्रीब्यूट करता है, मतलब 1 ग्राम जो है वो 9 किलो कैलोरीज कंट्रीब्यूट करता है एज कम्पेयर टू प्रोटीन एंड अमाइनो डेक्सट्रोज. तो कोशिश तो हम यही होती है कि जो है वो डेक्सट्रोज के हाई कंसंट्रेशन यूज़ करके स्ट्रिक्ट मॉनिटरिंग ऑफ ग्लाइसीमिया एंड और साथ में प्रोटीन कंपोनेंट्स को इंक्रीज करके हम एनर्जी रिक्वायरमेंट को मीट करने की कोशिश करते हैं, बट दैट इज़ नॉट 100% ऑल्सो. सो दिस वी विल डू इन आवर सेटिंग.
Thank you so much, Dr. Aisha. And we are done with our question and answer session. Thank you so much, everyone, for your questions. I hope you are clear now. Continuing on, now I'd like to call Dr. Aslam Shah. He is the Senior Manager of Pharmacy Services and Supply Chain of IHHN, serving for more than 25 years. His dynamic leadership and prolific motivational demeanor has helped construct and elevate the Department of Pharmacy Services from a single room med-surg store to present day's multifaceted department encompassing clinical pharmacy, extemporaneous and cytotoxic pharmaceutical services, ultimately leading to complete integration of pharmacists in every step of healthcare system. I humbly request Dr. Aslam Shah to grace us with his presence and express his views on today's session.
Can you hear me?
Yes, sir, I can hear you. You're audible.
Okay. A'udhu billahi minash shaitanir rajim. Bismillahir rahmanir rahim. Assalamu alaikum and good afternoon, everyone. I am very much pleased and would like to express my gratitude and thank you all for attending the 6th biennial Indus Hospital Icon 2022. We know that pharmacists are expert in drugs and medication use is a complex that begins with the multidisciplinary process that ends with the patient. Pharmacists are routinely practice the pharmaceutical care as a part of multidisciplinary patient care team to identify, resolve, and prevent the drug-related problems. As we see, the theme of ICON 2022 is beyond the call of duty. That is very much relevant with the pharmaceuticals care. The pharmacies are remain open round the clock, even during the COVID. We see during the COVID pandemic and complete lockdown situation, the pharmacist worked hard as an important frontliner and able to manage the patient services at required and beyond the expectations. As we see in our today's session, more than 240 participants attended this meeting online, and in all our campuses, the pharmacist and pharmacy technician and the other hospital administration, they see our webinar in the group in their meeting rooms. So special thanks to fantastic guest speakers of the session for sharing their experiences, especially Dr. Kamal, Dr. Sherif Kamal, who presented regarding the technology, oncology pharmacy management from good to great. And he discussed the technology introduced, atomization in medication management, and oncology protocol management, where the pharmacists explored their role. Thank you to Dr. Mujahid Hussain. He given the lecture on the antibiotic stewardship, and especially he said in his lecture that the resistance is developing against the antibiotics. So for optimization and rational use of antibiotic, the ASP, the action plan and goal is shared by Dr. Mujahid is very well. Thank you to Dr. Abdul Manan for introducing the pharmacy services implementations in the public institute, which is managed by Indus Hospital in Civil Hospital Badin, implementation of pharmacy services. Also, thank you to Dr. Aisha Hanif for her presentation on TPN and the requirement in the TPNs and the management in TPN preparations. She explained very well it. On behalf of pharmacy services and the Indus Hospital management, I would like to thank you once again, everyone, for your patience and participation. I will end my vote of thanks with the hope that the participant enjoyed the session, learn a lot from the national and international speaker lectures. And special thank you to Dr. Arif, Dr. Shafiq, Dr. Rafika for their outstanding efforts for managing this great session, the pharmaceutical session. Thank you all.
Thank you so much. This session is officially closed. Thank you.